Removal of colorectal adenomas during colonoscopy reduces the incidence of colorectal carcinoma, CRC, and CRC-related mortality. Despite surveillance of patients after resection of adenomas, the risk of developing CRC remains higher than in the general population. Moreover, it is known that CRC can be detected in the interval between scheduled surveillance colonoscopies. One of the important causes for interval carcinomas is incomplete removal of the original adenoma. As residual adenomatous tissue has been shown to be capable of rapid regeneration, incomplete resection may result in local recurrence. Several studies have indicated that incomplete removal contributes to a higher subsequent incidence of CRC. Concerns regarding local recurrence exist mostly for lesions with nonpedunculated morphology, which are often removed by endoscopic mucosal resection, EMR, with submucosal fluid injection. The issue of residual tissue seems to be more pronounced after piecemeal resection, which is at least in part due to the difficult histological evaluation of resection margins when lesions are resected in pieces. To reduce the risk of interval carcinomas secondary to local recurrence after EMR, international guidelines recommend that follow-up colonoscopy is performed 2 to 12 months after endoscopic resection of flat and sessile lesions. The recommended time interval for the first follow-up colonoscopy varies within and between guidelines depending on size, morphology, and resection method used. Currently, there is no strong evidence pointing to specific risk factors for local recurrence, nor is advice for appropriate intervals of follow-up available. Belderbos et al. Assessed the magnitude of the problem of local recurrence after EMR of flat and sessile adenomas and minimally invasive carcinomas by performing a systematic review and meta-analysis. They also aim to identify risk factors for local recurrence and to determine the optimal timing for the first follow-up endoscopy after EMR. This is to be done in order to individualize recommendations for surveillance. They report their findings in their study entitled Local Recurrence After Endoscopic Mucosal Resection of Non-Pedunculated Colorectal Lesions, a Systematic Review and Meta-Analysis. Here is a summary of their report. Background and study aims. Local recurrence has been observed after endoscopic mucosal resection, EMR, of non-pedunculated colorectal lesions. The indications for follow-up colonoscopy and the optimal time interval are currently unclear. The aims of the systematic review were to assess the frequency of local recurrence after EMR, to identify risk factors for recurrence, and to provide follow-up recommendations. Methods. A literature search was performed in PubMed, Embase, and the Cochrane Library. EMR was defined as endoscopic snare resection after submucosal fluid injection for removal of non-pedunculated adenomas and early carcinomas. Local recurrence was subdivided into early recurrence detected at the first follow-up colonoscopy and late recurrence detected after one previous normal colonoscopy. A random effects meta-analysis was performed to calculate the pooled estimate of risk of recurrence. Results. A total of 33 studies were included. The mean recurrence risk after EMR was 15%, 95% confidence interval, 12 to 19%. Recurrence risk was higher after piecemeal resection, 20%, 95% confidence interval, 16 to 25%, than after en bloc resection, 3%, 95% confidence interval, 2% to 5%, with a p-value of 0.00001. In 15 studies that differentiated between early and late recurrences, 152 out of 173 recurrences, 88%, occurred early. In 4 studies with follow-up at 3, 6 and 12 months, 19 out of 25, 76% of recurrences were detected at 3 months, increasing to 24, 96% at 6 months. In multivariable analysis, only piecemeal resection was associated with recurrence, 3 of 3 studies. Conclusion. Local recurrence of the EMR of nonpedunculated colorectal lesions occurs in 3% of en bloc resections and 20% of piecemeal resections. Piecemeal resection was the only independent risk factor for recurrence. As more than 90% of recurrences are detected at 6 months after EMR, we propose that 6 months is the optimal initial follow-up interval.